Today we'll talk about oral and maxillofacial trauma in general, in basics, let's say. Now, the outline will be an introduction first, the initial management of the trauma patient, soft tissue injuries, dentoalveolar injuries, mandibular fracture, maxillary fractures, zygomatic complex fracture. Now, as an introduction, we need an accurate and systematic manner for assessment of a patient with any injury. Any trauma patient, we need to be able to assess him systematically and accurately. Look at the important things that can save the patient's life. Now, nearly 25 to 33% of deaths can be caused by injuries, and they can be prevented by an organized or systematic approach. Now we have three peaks of death. Now, due to trauma can happen due to three peaks. The first one, death happens within seconds or minutes, like injuries to the aorta, injuries to the brain, injuries to vital organs. They can cause death within seconds or minutes. The second peak, it has the golden hour of resuscitation. The first hour can be very crucial to save the patient's life or send him to death. The first hour is very important. Now, in children or kids, we have the golden half an hour, 30 minutes. That's the amount that we have. So if the patient comes within the first hour and we start to deal with him systematically and accurately, the patient can make it out of it, can be saved. Now, in the second peak, these are injuries like shock, hemorrhagic shock, or injuries that can be devastating if we keep the patient waiting. The third peak, usually the patient dies after a few weeks or months because of multiple organ failure or sepsis. Now, as an injury that comes to the ER, they can be non-urgent, urgent, or severe. Non-urgent injuries, they are 80% of the injuries that come to the ER. Patients who are cold cases trying to make the clinic appointment come faster, or if it's a trauma, it would be non-urgent, doesn't need that much attention. We leave it aside. Urgent cases, like 15% of the injuries, and these require good resuscitation. So here patients have stable vital signs and no threat to life. But if we wait on them, it can be a threat to life. Like appendicitis patients, you need to make the assessment and everything very fast, but you cannot leave him waiting. The severe cases, injuries to the aorta, injuries to the brain, injuries that can cause death, they are 5% of the cases and they need immediate management. Now, to classify injuries, we have the Glasgow Coma Scale. It's from 15 points. 6 points are given to motor response, 5 points to verbal response, and 4 points for eye opening. So a normal patient will have 15, a mild injury would be between 13 to 14, a moderate injury between 9 to 12, and severe between 3 to 8. The least amount that the patient can get is 3. 1 for eye opening, 1 for motor, and 1 for verbal. Okay. Now, eye opening, if the patient opens his eyes and closes them spontaneously, without any command, without any pain, without any stimulus, we give him 4. If he opens to speech when you tell him open your eyes, close your eyes, that's 3. To pain, when you pinch the patient or apply pain to the patient so he can open his eyes, that's grade 2. And 1, no response whatsoever. For the motor, the patient obeys commands. If you tell him flex your arm, extend your arm, move your legs, he does it without any problems. If he localizes pain, that's 5. If when you press on the painful site, he localizes it. He localizes the painful site. This is 5. Now, if when you press on the painful site, all the extremities withdraw from the pain, they go away from the pain site, that's 4. If there is flexion to pain, meaning the patient's arms and flexes towards the inside, towards the midline, that's 3. If extension away from the midline, 2. 1, nothing. Verbal oriented. The patient, when you tell him, what's your name? My name is John. Where are you? In the hospital. He knows everything around him. That's 5. If there is confusion, he doesn't know where he is, or he doesn't know what day it is, or he doesn't remember his name, that's 4. If he says inappropriate words, that's 3. Meaning, inappropriate, like you ask him, where are you? I'm dreaming. That's his answer, for example. Or where are you? He says the sky is blue. So if there are not appropriate answers to the question. If he says incomprehensible words that cannot be said words, only he mutters anything, that's 2. And nothing, 1. Now there are some life-threatening injuries, like evidence of collision involving high energy dissipation, fall of 6 meters or more, evidence that the patient is in dangerous environment, burning building, icy water, automobile accident in case it takes more than 20 minutes to remove the patient, significant damage to the passenger compartment, rearward displacement, death of other passengers, ejected from the vehicle. All of these are life-threatening injuries, and patients need extensive monitoring and CT scan. Now, the first thing we need to do is the primary survey. Airway and C-spine, breathing, circulation, disability, exposure, A, B, C, D, E. Now, in some time back, like in 2019, 2020, they came up with the circulation first. But they found out it doesn't actually fit. Because if we can bring back circulation, but we don't have an airway, what's that going to do? The brain can accommodate hypoxia for about 4 minutes. So, okay, let's bring back circulation. It might need 15 minutes, but to the brain does not get enough air. So, everything we did is not sufficient enough. So, for airway, we need to establish and maintain a patent airway. We need upper airway obstruction can happen due to foreign objects, rearward displacement of the tongue due to the muscles, bleeding from the oral facial structures. Now, we can do it either with a head tilt, chin lift. We apply our palm on the head, on the forehead, and lift the chin with the other hand. That's good, but in the patient, if he has a cervical spine susceptible injury, we do not go for it. We go for the jaw thrust because it's safe. We keep the cervical spine as it is, and we push the jaws anteriorly to push the tongue forward and to push the muscles forward and to open the airway. We can sometimes use oral airways or nasal airways to help. Now, once we've done this, we put a clothed finger, we put gauze on our finger, and start to clean the oral debris from inside. Now, as for breathing, if the patient is breathing spontaneously, we feel and listen to the air movement. We might need supplemental oxygen. But if the patient has exchange of air, this does not guarantee adequate ventilation. The chest wall the patient can have pneumothorax, flail chest, hemothorax, and may move but does not ventilate effectively. Very slow or rapid rates of respiration suggest poor ventilation. Now, changes into thoracic pressure can convert simple pneumothorax into tension pneumothorax. Now, the signs of chest injury can be hypoxia, subtle and anxiety, increased rate of breathing, a change in the pattern, more, faster, and shallower breaths. So tachypnea and shallower breaths. Now, some life-threatening injuries that we need to be careful with them and treat them properly: open pneumothorax, flail chest, tension pneumothorax, and massive pneumothorax. Now, when should we suspect a pneumothorax? If a patient becomes rapidly ill, severe respiratory distress, decreased breath sounds, hyperresonance on one side of the chest, the air is hyperresonant, neck veins that are distended, and deviation of the trachea away from the involved site, usually towards the other side of the injury. Now, what is pneumothorax? Pneumothorax is air in the pleural space. This can be due to open or closed pneumothorax, either a penetrating injury or closed due to the trauma and the pressure. So here we will have the lung shrinks. Now, patients can have sudden chest pain, shortness of breath, tachypnea, hypoxia, and so on. To manage it, we need to put a three-way dressing to keep it one way open so the air can pass out of it and do not increase the intrathoracic pressure, chest tube, and sometimes surgical repair. Now, sometimes you can have a flail chest. Usually it's a flail segment, multiple ribs fractured at multiple sites. Okay? Now, before we talk about flail chest, let's talk about the management of a pneumothorax. If it's a small, we admit the patient and close observation. If the patient is otherwise healthy, symptom-free, no need for general anesthesia, and does not increase on serial x-rays on 24 hours x-rays, we can discharge the patient after a few days. But this is rarely the case, and we need to place a chest tube. Now, a chest tube usually it has 3 centimeter long incision. Usually we place it in the 5th intercostal space, mid-axillary line, or the mid-clavicular line, 2nd to 3rd intercostal spaces. Then we take upright, posterior, anterior, and lateral chest radiographs to make sure that the position of the chest tube and the drainage holes are all good. We prefer mostly the mid-axillary line for cosmetic reasons. Here you can see an X-ray with right pneumothorax. Now, for flail chest, as for flail chest, to manage it, we need to stabilize the respiratory function. We need to give the patient good pain management. We prefer not to use narcotics because they can use respiratory depression. We need to give them supplemental oxygen and positive airway pressure. Now, usually, we do not need to do surgical fixation, only to make sure that the airway goes back and everything goes good. And sometimes, with good management, the patient can go out very good. Now, we have something called tension pneumothorax. Here we have it works as a one-way valve. Now, the meaning of one-way valve, the air enters on aspiration and doesn't get out. It goes in but doesn't get out. That's called tension pneumothorax. And here we will find shrinkage of the lung that's injured and that needs good management, because if the patient does not get managed properly. Now, it can be spontaneous or traumatic from any injury. Now, the management for it, needle decompression, and so we make a path for the air to go out. Now, symptoms: shortness of breath, acute chest pain, reduction of blood pressure, reduction of the oxygen, and increasing the heart rates. Now, Hemothorax, it's accumulation of blood in the pleural cavity, and this due to an injured vessel sometimes. The management as well as chest tube. Now, as for circulation, it's very important to find out any bleeding vessel, any bleeding artery, anything like that. We need to manage it properly. Hypovolemia is the most common cause of shock in the traumatized patient is hypovolemia by hemorrhage, external or internal. Now, the main way to find out if there is bleeding or if there is not good circulation, it's the tissue perfusion or skin perfusion. It's the most accurate test that you can use. But during the primary assessment, we put two large bore needles for fluid resuscitation. Now, for compensation of the fluid loss, there will be vasoconstriction of the vessels to the skin and the muscles, so there will be sweating during palpitation, the skin may feel cool and damp. So there will be shifting of the blood towards the most important organs, the brain, the muscles, the heart, to give them the lungs, to give them the good amount of blood, and the rest of the body reduced amount of blood. So there will be tachycardia and hypotension in cases of trauma or hypovolemic shock. Now we need to check also the capillary refill time, which is required for the blood to return to the capillary beds. Usually less than 2 seconds. If it's less than 1 second, hyperdynamic state. If it's more than 2 seconds, poor perfusion. Now here we can see the hypovolemic shock. Usually less than 750 class 1 milliliters, of course, loss of blood. 15% blood loss. The pulse rate is less than 100. Blood pressure normal, pulse pressure normal, respiratory rate within normal, urine output within normal. Now, for class 2, we will find the pulse pressure decreased, but respiratory rate and urine output the same, 20 to 30. The first signs of reduction of blood pressure is in class 3 hemorrhagic shock. The heart rate would be more than 220, and the amount of blood lost is 1,500 to 2,000 milliliters, up to 2 liters lost. Class 4, more than 2 liters lost and more than 140 heart rate, the blood pressure decreased, and the urine output is negligible. For class 1 management, we give crystalloid solutions. For class 2 and 3, crystalloids and blood. For 4, crystalloids. Now, the most common fluids that we give for these patients is lactated Ringer's solution or 0.9% normal saline, but the one that's preferred is lactated Ringer's solution. Now, colloids and artificial plasma expanders that treat hypovolemia is still controversial because the cost does not appear to be justified by clinical data. Now, sometimes we need to transfuse blood, as we said in class 2 or 3 blood loss, hemorrhagic shock, Now, sometimes the safest blood to administer is the blood that has been fully cross-matched, and usually we need to place O negative blood so it can be given to anyone with an injury. Now, for disability, For disability, we need to assess the patient's neurological wise, to assess the eye opening, to assess the movements of the eye, the pupil reaction, to assess if there is any neurological injuries, and exposure to assess if there is any internal bleedings or anything like that. Now, we'll talk about soft tissue injuries. Now, regarding soft tissue injuries, these can be a lot. We can have abrasion, laceration, contusion, avulsive injuries, animal and human bites. So abrasion, just scratches or what we call uh, or what we call superficial loss of the epithelium. Here it just needs regular cleaning and dressing for this case. Contusions, collection of blood. Now, this, like in this case, sublingual hematoma. These are very risky and we need to maintain the patient and observe him. Sometimes these patients need intubation. Sometimes they might need evacuation, sometimes after fixation everything goes good. Avulse of injuries or lacerations, like in this case, and dog bites or animal bites. Here you can see a laceration case and the suturing of it. Now, for animal bites, the most important thing is that the most common source of infection is Pasteurella multicoda bacteria. These patients need antibiotic prophylaxis. Cat bites have higher twofold infection rates compared to dog bites. We do the dressing, we do the immediate closure, it's safe, a 6% risk, with antibiotics, amoxicillin and clavinic acid if the patient is allergic, clindamycin. We follow them up after 48 hours because most of the cases there will be an infection. Or not most of the cases, some of the cases there will be an infection. There will be an infected site, there will be pus sometimes after 2 days. So that's why we follow up these patients after 2 days. Now in this case we have avulse of injury. Now the first thing that we need to do is to replace the tissue and suture the corner. After we suture the corner, start to suture everything, but in cases of lip involvement, we need to suture first the vermilion border because a 1 millimeter difference can be visible. Now, bone healing can be direct or indirect. A direct in which we have gap healing or contact healing, in which there will be bone formation immediately, starting the osteoblast and osteoclast and so on. Sometimes we have secondary healing, which is formation of the fibrous callus, and then this callus can be transformed into bone. Now, we have what we call rigid internal fixation, in which there is no micro movement between the two fractured segments. Non-rigid, we can have a slight movement, micro movement. Now, functionally stable fixation, like in cases of angle fracture, we allow the patient to still function, but it suffices the function. The patient can still function and the fixation does not get affected. And load-bearing fixation or load-sharing fixation. Regarding the load-bearing, in which the whole load, the whole force, the plate takes it. For load-sharing, the plate and the bone take some share the forces applied on them. So here in this case we have rigid fixation, non-rigid fixation. Here non-rigid in both ways will not allow the muscles, will not allow the bone to heal properly. But when we have rigid fixation on one side and non-rigid or functionally stable fixation on the other, we can manage the case more proper in this case. Now for dentoalveolar injuries, these mostly happen in children. We can have crown infarction, we can have crown fracture to enamel or enamel and dentine, enamel, dentine and pulp, crown root fracture, non-complicated, complicated, and root fractures. We can have a concussion injury. We can have a lateral luxation or subluxation. We can have extrusion. We can have avulsion and intrusion with also dentoalveolar fractures. Now, for management of these cases, for the crown infarction, just the chip, we just do composite resin and we do pulp vitality 6 to 8 weeks later. For crown fracture without pulp involvement, protection of the pulp with composite or glass ionomer filling. Crown fracture with pulp involvement. If the pulp is vital and we treat it within the first 2 hours, we put direct pulp capping for small pinpoint exposures. If we have an open apex and a small pulp exposure, within 24 hours, we pulp cap it and with calcium hydroxide. Open apices over 24 hours, calcium hydroxide pulpotomies, and later on might need RCTs. For vital pulp with a closed apex within 24 hours, direct pulp cap. If larger than 1.5 millimeters or more than 24 hours, root canal treatment. Now for crown root fracture, if we have longitudinal following the long axis of the tooth, extraction, more than 1/3 of the clinical root. If it's above or below this cervical margin, we go for conservative therapy or crown lengthening or orthodontic elevation. For root fractures, the apical and the middle parts are the most common. Here we don't need to do anything unless excessive mobility is present. We will need to splint them for 12 weeks. But for cervical third, extraction. For periodontal injury, concussion, usually we just have the periodontal ligaments have been pressured, but there's no cutting of the periodontal ligaments. Here the patient will be having the symptoms of a hot tooth, tender to percussion, tender to biting, so we just do occlusal reduction. Subluxation, also occlusal reduction and vitality testing 6 to 8 weeks later. For intrusion, it has the highest rate of pulpal necrosis. If incomplete root formation, we allow it to re-erupt 3 months. If it doesn't happen, then we go for orthodontic extrusion. Complete, we reposition, splint for 2 weeks, and then RCT. For extrusion, non-rigid splint 2 to 3 weeks, lateral luxation splint 2 to 8 weeks. If we have avulsion, a mature tooth, 7 to 10 days. Replanted tooth immature, 3 to 4 weeks. Now, an avulsion in which the tooth has been out of the socket. We need to re-establish the periodontal ligament physiology. If it's more than 15 minutes, the cells would be mostly dead. We have multiple mediums like milk, saliva, saline, HB, Hanks balanced salt solution, VSPA. Now, milk is the medium of choice if we don't have Hanks balanced salt solution or VSPA, but it works less than 20 minutes and keep them vital. Hanks can store the tooth for 24 hours, VSPAN up to a week. And that's how we manage it in cases of avulsed teeth. Here's a summary to what to do in these cases. Now, mandibular fractures. According to mandibular fractures, they can have multiple classifications according either to the anatomy, the symphysial fractures between the lateral to lateral, from the lateral towards symphysial and parasymphysial from the lateral to lateral. If it's anterior to the mental foramen, we can call it parasymphysial between the lateral and the mental foramen. From the mental foramen towards the last molar, body fracture, angle, ramus, coronoid, condylar neck, condylar head. Now, the condylar neck and the head together, they are the most common fractures. But sometimes they say the symphysial is more common, sometimes they say the angle, so it's not still agreed upon. Now, we can have favorable or unfavorable fractures. Favorable fractures in which with the movement of the muscles, there will be fixation or reduction of the fracture that goes back to the position itself. Unfavorable with the movement of the muscles, it does not work properly. The fracture will open. We can have simple fractures or complex. either segment fracture, comminuted fractures, gap fractures, and compound or complex fractures. Now, any fracture that we might get, it has two forms of management. Either non-surgical, we don't need to do anything, just observation, or closed reduction in which we do not open at the fracture with MMF, IV loops, arch bars, or plates and screws, which is called open reduction and internal fixation, ORIF. So here's the arch bar, the IV loops, and the plating. So here we can see condylar fracture with plate on it, and a parasymphysial fracture with two plates to fix it. And the mental nerve, as we see, is protected. Now, for cases of symphysial, parasymphysial, when we want to place plates, we usually place two plates 4 to 5 millimeters space between them to cover the compression and the tension lines to prevent flaring of the fracture. Okay. Now, as for maxillary fractures, we have the Lifford fractures. Lifford 1, it's a horizontal fracture from the lower part of the nasal ala and the maxillary bone, all of it fractured. It's a horizontal fracture. Of course, with the involvement of the pterygoid plates. To call it Clifford, there will be pterygoid plate fractures. Type 2, involving the infraorbital foramen. So the paresthesia of the infraorbital area would be more common with the Lifford 2 fractures. For Lifford 3, the ZF or the zygomatico-frontal suture will be involved. And if there's no displacement, we can keep the case, we can observe the patient with no disturbance to occlusion. If there is disturbance to occlusion or displacement, plating is the management. 4 plates, L-shaped, after replacement of the bone to its position. Now for zygomatic complex fracture, we have class A fractures, which is isolated one of the segments. Now, zygomatic complex was known as tripod, the zygomatico-frontal suture, zygomatico-maxillary suture, and zygomatico-temporal suture. But then they added the zygomatico-sphenoid suture, so it's now a quadruple fracture if it happens. For class A, one of the sutures is fractured, either the arch isolated, zygomatico-frontal, or infraorbital. B, monofragment, so we have separation of all the 4 sutures, but as a segment without comminution. C, with comminution. Now, if isolated arch fracture, we can go for the Keen approach if there is displacement and facial depression, or the Gillies approach. The Gillies, we open a 2 cm incision in the temporal area below the hairline with the Rowe forceps until we hear a click. For the Keen approach from intraoral, we click it back into its position. For low energy, if there is no, or class A without any, if there is no displacement, no muscle dysfunction in ophthalmos, observation. Middle and high energy fractures, we go for ORIF, open reduction internal fixation. If the arch is present, we fix it first. If it's not present, we expose all the fractures, fixate the zygomatico-frontal suture first, the zygomatico-maxillary suture, then infraorbital, and then the orbital floor. And the last thing we need to talk about is the naso-orbito-ethmoidal fracture. As you can see, class 1, separation of one of the sutures or one of the segments without comminution, but the medial canthus is still attached. Class 2, more comminution with the medial canthus still attached Class 3, severe comminution with loss of the medial canthus. As you can see here, we see plates placed for the NOE fracture. And we have what we call panfacial fractures, in which we have complete fractures or more fractures of the facial structures. We have vertical and horizontal buttresses. For the horizontal, you have the frontal, zygomatic, maxillary, mandibular. For the vertical, we have the nasomaxillary, zygomaticomaxillary, pterygomaxillary, and posterior mandibular or condyle. Now we have two approaches: bottom up, inside out, up down, outside in. Now here we need to see the part that we can fix, or the part that is fixed that can give us good reference to fixate the fractures. Then we start to go to other structures. So for example, for the bottom up and inside out, we do tracheostomy first, repair of the palatal fractures if it's present, MMF to restore the occlusion, fixate the mandibular condyle, then the mandible fracture, then zygomatic complex fractures with the arches, frontal sinus, naso-orbito-ethmoid, and then the maxilla. For the top down tracheostomy, frontal sinus fractures, ZMC, then NOE, Lefort, MMF, maxillomandibular fixation, bilateral subcondylar fractures, and then mandibular fractures. And thank you. This is the oral maxillofacial trauma lecture in summary, let's say, or collection of things, so it can guide. And if you have any questions, I'm always available. Thank you.